Hello, everyone, and welcome to Headwise, the weekly podcast and videocast of the National Headache Foundation. I'm Dr. Lindsay Weitzel. I am the founder of Migraine Nation, and I have a history of chronic and daily migraine that began at the age of 4. I am excited to tell you that I am here today with Dr. Tim Smith. Hi, Dr. Smith, how are you?
Doing very well. Thanks for having me again, and thank you for everything you do for our headache constituency out there. It's a lot of great information, and I know everyone appreciates it.
Well, thank you for being here. We're always honored when we have Dr. Smith. We bring him on for our monthly news episodes where we have so many updates to tell everyone about. It's very exciting. He is a regular on our show because of his extensive experience with clinical trials with migraine medications, etc. He is the CEO of Study Metrics Research, and he is also a board member of the National Headache Foundation. So we have lots to report to you today. So we're going to get right to it. Among our announcements are 4 new data alerts related to headache and migraine, etc. We're going to start with one having to do with the CGRP medications. We have actually been waiting for some time for a study that would compare our various monoclonal antibodies against CGRP for migraine head to head so that we might be able to compare their safety and efficacy, etc. We do have one of those to report today. It is not maybe the most robust study we've ever reported. It's a little bit small. But Dr. Smith, what can you tell us about this new study? I think it compares about 3 of these medications for us.
Right. It compares Iranumab or Aimovig with fremanezumab or Ajovy and galcanezumab or Emgality. So these are the 3 subcutaneous injectable monoclonal antibodies. And we, as you pointed out, we don't have head-to-head data to compare these. People many times will compare the data from the different labels in the FDA approved information, the studies that were submitted for their approval. And, that's what we have, and people can draw their conclusions from it. This was an Italian study that was done at a reputable, headache place in Italy. And it's not a prospective head-to-head study. It's not randomized. But it did compare similar populations, albeit small. It was a total of 140 patients that were screened into the study, and this was called a retrospective analysis. So we took data from their medical records and were able to do some analyses because they have a very structured way of enrolling patients in the clinic there, and they see them at regular intervals, and they capture the same data, MIDAS scores, migraine days, and those kinds of things. And so they were able to, after a period of time, it wasn't quite a year, but they had similar populations of patients. Baseline data looked similar, and they were able to compare across the 3 different molecules.
Okay.
And so
what did they find?
The results show that they were very similar. So,
Okay.
it's not surprising, I suppose, but there wasn't a clear winner in this study. If the study had been bigger and prospectively done, we might have seen a clear winner, but if it's bigger, then the effect size is smaller. So it becomes less relevant to do bigger and bigger studies, although you can prove a statistical correlation. I don't want to get too far into the statistical methodologies of it, but it is what it is. It's a small study, well done in retrospective data, and showing that from an adverse event perspective and from an effectiveness perspective, there was not really a significant difference in the 3 molecules according to this analysis.
Okay. All right. Well, good to know for now. That's really our first bit of data we've seen comparing them. And for now, we don't seem to have anything standing out among our monoclonal antibodies for migraine. Our next study we're going to move to is actually a GPANT study. It's looking at one of our GPANT medications, that's already available. This is another new data announcement we have today. It's looking at Ubrelvy. It's been tested in a new manner in this study, meaning the timing of the medication. They they gave it at a different time in this particular study. This was called the PRODROME study. What can you tell us about this one?
Well, I think the name gives it away. It's about prodrome.
Sorry, I stole your thunder.
No, it's okay. Most of our viewership, understands what the prodrome is. And a lot of people are, even if you don't have migraine or don't know someone who has migraine, a lot of people are familiar with what the aura is, and that's usually a visual or other neurologic disturbance that will herald the onset of an attack within an hour. But these prodromal symptoms are other more vague or insidious kinds of symptoms that may start even as much as a day before a migraine attack, the pain part of the attack actually begins. And what we looked at, what this study was looking at was what would happen if you treat during that time. And historically, researchers have tried to look at this before, and it's always difficult because if you treat a patient who doesn't have a migraine and then they don't have a migraine, did you really do anything? Becomes the issue. And that's always, that's been the criticism for these kinds of studies. But this is a well-done study where they identified patients who could reliably, at least 75% of the time, would have migraine attacks within 1 to 6 hours following onset of these more insidious symptoms. And you can read various accounts of what the usual prodrome symptoms are. The ones that showed up in this study at least 30% of the time or more were things like sensitivity to light, fatigue, neck pain, sensitivity to sound, and also dizziness. And I think we recognize that some of those symptoms are actually symptoms of migraine, but we're not talking about migraine pain that's accompanied by the light, noise sensitivity, or nausea. This is where patients will inexplicably have nausea as much as 6 hours prior to onset of their recognizable migraine study. And so 60% of people are said to have a prodrome, recognizable prodrome. But we feel like there may be a lot of people who have not really paid attention. They sort of kind of have days they don't feel so good and they don't put it together with their migraine attacks. But this study actually prospectively identified those people that have the not feeling so good that actually would reliably predict the onset of a migraine attack within 6 hours. And then they put them into a study where they treated either with the placebo or with Ubrelvy, and then they crossed them over. The patients came back in for a clinic check, and then they gave them the other treatment. So they got both treatments, but it was blinded to the assignment, and so patients couldn't know which one was which because they looked identical and that sort of thing. And so for these patients that had 75% could actually identify reliably onset of prodromal symptoms that heralded a migraine 75% of the time, what the study showed is that almost half the time, if they took the Ubrelvy during the prodrome and before the migraine attack started, they could prevent the development of a moderate to severe migraine attack almost half the time, of 45 and point something percentage of the time. So, and that was highly statistically significant compared to placebo. And so these are the first and best data that we've seen that look at this phenomenon of treating during the migraine prodrome.
Right. It is very interesting. It did not necessarily, the study was not able to tell us that whether or not the medication worked better if you took it in the prodrome, correct?
Right.
Unfortunately, it did not get to that point, but it was able to stop the migraine before the pain phase started, I think, in some cases. I think this is what we're trying to get to here with a medication treatment by being able to take it in the prodrome. So this is interesting and exciting information for those of us with migraine, especially if we are good at predicting the migraine before the pain phase hits. So I thought that was a very exciting study. It was well done, and it sounded like it took a lot of work to carry it
It
out.
did, it did take a lot of work.
Yes,
We
on
did
the
the
part of
study
the
in my
patients.
clinic, and
Yeah, on the part of
it was some
everyone.
work. Yeah.
Yes. So the next announcement we have is a device announcement, and it is related to a device that is already available to us that many of us know about. It's the Nerivio. It's the one that goes on our arm. So it's a very popular device, and it has received a new clearance from the FDA. Many of us know it's worn on the upper arm, then it is operated through an app on our smartphone. So, Dr. Smith, what new information do we have for our use of the Nerivio device?
Right. So we've covered the Nerivio device before, and I think most of
Right.
our viewership is familiar with it. It's what we call remote electronic neurostimulation, or REN therapy, REN therapy. And it's previously already FDA approved for abortive therapy, and it's actually
Right.
approved for adolescents as well as abortive
Mm-hmm.
therapy for migraine. And they conducted a large study showing effectiveness and high degree of safety and using it regularly as a preventive. And so this is not just a study announcement. This is actually an FDA approval announcement that they've done. They published their study results, and it was a well-done study. They did the usual thing, even though this was not a medication study. They did start with a baseline capture, so they get their baseline migraine frequency numbers for this population of patients, had them track the electronic diaries through the treatment periods, and then they could compare the frequency of migraine attacks after institution of the regular use of the device to their pre-implementation numbers. And basically, to cut to the chase, what the information showed was there was about a 4-day improvement in migraine days compared to baseline, and the placebo group only had a 1.3 day improvement. So not that we really compare studies across different populations,
Right.
it's not a head-to-head study, but if you look at the other data that have been reported for preventive interventions, these are quite good results. To have a
Right.
4-day, if you're going from 6 migraine days per month to 2, that's substantial,
Yeah.
especially if they're bad, and if compared to placebo. And so a lot of our studies, we look at the placebo response rates are kind of high too, and that's always a perplexing thing for us. And people always subtract the difference between the placebo from the active treatment arm, and there's some problems with doing that methodologically. But if you do that with this one, these were good results for a device that doesn't involve taking a medication and can be easily
Mm-hmm.
used, operated by the
Right.
phone. We talked about it before. So
Right.
interesting, and it's FDA approved now as a preventive, so that's a good thing.
Right. So that is very exciting, and that is one of the options that we have for people, younger people too, for those of us that have children with migraines. So we do love talking about those options.
Yeah.
We are going to move on to a study that was published last month on intranasal ketamine. This can be a controversial topic. Um, it has ketamine does have the possibility to be used as a drug of abuse. So some people think it's controversial. And we actually have a podcast coming up later this month on the use of ketamine in the treatment of migraine. It can be used inpatient, outpatient, and in this case, we are talking about a recent study on intranasal ketamine. So tune in if this is something that you would like to learn about or you've heard about. We will be having another episode on this medication. And in this case, this was a study for refractory migraine, which really this medicine is mostly used for people who really have chronic, debilitating refractory migraine. So, Dr. Smith, this particular study on intranasal ketamine, what did they find?
Yeah, so it's this is as you pointed out, the use of ketamine for difficult migraine, chronic
Mhm.
migraine. It is somewhat controversial. For those of our listeners who don't know what ketamine is, it's basically an anesthesia thing. It's used as an adjunct or as an anesthetic for surgeries and the like. It's been around for a long time. It's an offshoot of PCP, which we
Mhm.
know to be a drug of abuse.
Right.
And the interesting thing that ketamine does is it can very strongly block pain impulses. And in fact, in the 60s, when this was first being sort of developed for human use, it was first used in soldiers in Vietnam. And the reason they did was because they could administer this for people with battlefield injuries, and it would very effectively block their pain impulses from devastating injuries until they could get them
Mhm.
medevaced out to a place where they could get definitive care. But going on from that, it went on to become an anesthetic, but it's actually been developed as a nasal spray for other indications. But
Mhm.
people have used it for mental health disorders, and it's been used by some headache clinicians as a treatment for an acute treatment for migraine. And then it's been an interesting process to see this evolve, because there are some prospective studies that have been done, but they're very, very small and inconclusive. There are better studies, I understand, underway or soon to be started, and they can be found on clinicaltrials.gov. You can look up ketamine on that if you're interested in knowing about where they are being performed, and
Mhm.
a lot of them being done in Europe, for example. But in this study, this was another one of these retrospective studies. It was done at a tertiary headache center, a very reputable headache center in the U.S. And what they did is they interviewed patients, and the population was 242 subjects that were screened and went through the interview. And they basically interviewed them about effectiveness and quality of life and functionality and those kinds of things. And I thought one of the interesting things is that the median number of monthly migraine days, or headache days rather, was 30. So this
Yeah.
tells you this is patients had this. They were a chronic daily, everyday
Right.
population from the jump,
Yeah.
and most of them, they on average they had tried 4 previous preventives. So these are your tertiary headache center population, which
Yeah.
obviously these are the patients that would be candidates for something controversial like ketamine.
Mhm.
But the patients were using ketamine nasal spray, and overall they used up to 6 sprays per day with a median spray use of 10 days per month. So this is fairly frequent use, but they weren't using it every day necessarily.
Mhm.
And about half the patients reported this to be very effective, and their quality of life was considered to be much better in about a third of the patients. About 2/3 elected to continue to be current intranasal ketamine users, and about 3/4 of them had reported at least one adverse event. And these are usually nausea, somnolence. Sometimes there can be a hallucinogenic type,
Mhm.
psychedelic type feeling, a little bit of a detachment, or sense of being separated, being outside of your body or whatever, some odd sensation like that.
Right.
But very, very few people found adverse events to be bothersome enough that they would elect to discontinue it. Most of them continued in the study, and if
Right.
they stopped, they didn't stop because of adverse events. It would have been more for a lack of treatment. success.
Right, right. And somnolence, you use that word. I want to make sure everyone knows that means sleepiness.
Okay.
So basically, it was pretty effective in this population, and there were adverse events, but they weren't so bad that people thought it wasn't worth it, because it seemed to be helping their pain in this group. So there is our new intranasal ketamine data. We do have one more study that is not a drug alert or a medication or device alert. It is just something super interesting. It is on weather, and since it is summer and we have changing weather, I thought this was going to be fun to report. I personally am very triggered by weather changes, and I wasn't when I was younger. And I don't know if that's just a change for me, or if it's because I was so sick when I was younger and already had daily migraine pain and everything else. So I didn't notice when things would get worse from weather. Who knows? But I notice now, I notice weather changes. And we have this study that's super cool. They used an app to analyze weather changes related to headache data. What types of things did they find related to weather that are triggers for us?
Well, so I'm from the lower Midwest in the St. Louis area, and we have the most topsy-turvy weather cycles. We definitely have 4 seasons. We have 4 seasons sometimes in the same week, and it's we have storms. We have the whole measure of things, and so we've made the observation in the clinic so many times. We have so many of our patients that say, I could be a weather forecaster because I can tell you, what the weather's going to be based on my headache occurrence. And that is a very common story. And many people are like you, they have that knowledge that their migraine attacks are associated with weather change. But proving it in a study has been the difficult thing. And I've been part of some of these kinds of studies. And while we've been able to identify things like lightning strikes and things like that, that may be indicative of turbulent weather that can be associated with migraine attacks, getting quality data to publish in a journal has been, it escapes us unfortunately for the most part. But this study was done by some Japanese researchers who looked at weather events and had patients track their headaches through their weather app. And they had some very compelling data showing that these changes, basically what they identified, there were like 4 events that seemed to be highly correlated with their migraine attacks. And these were low barometric pressure changes, so going from low to high or high to low, not specified one way or the other. I think patients report what's germane to them. And then higher humidity and rainfall activities were associated with increased number of headache occurrences. As we said, the study was carried out in Japan, so I don't know if there are regional influences or population characteristics that might be pertinent to them, but not generalizable. But it helped to have it in Japan because these researchers had access to the weather data, and they could match it up with with the migraine diary data in the weather in their migraine app. And so anyway, it's interesting. It would be great to redo this study in different areas of the world to see if these results are generalizable. So I guess your take-home message would be, for your migraine patients that have weather sensitive phenomena, headache phenomena, they should look for a place where the barometric pressure doesn't vary very much and humidity is low, and rainfall is
rare.
At least rarer, probably somewhere like Colorado or something, don't you think?
No, because you would think that, but our weather is ridiculous. It will change 4 times in a day, from snow to sun to, it's really bizarre and pretty miserable. And I sometimes wonder if the altitude adds a little trouble. So I would not recommend coming here.
Stay away.
So anyways, well, thank you so much, Dr. Smith. This was a great episode. had so much great to tell everyone, and we will be doing this again next month with anything new that has come out. So stay tuned, everyone, and stay tuned for our weekly podcast and video cast. You will be hearing from Headwise again next week. Bye-bye, all.